Assalamu alaikum, dear friends. Today I am going to discuss with you people about the hypertension in pregnancy. So there are different categories of the hypertension in pregnancy, like the PIH, that is pregnancy induced hypertension, which is also known as gestational hypertension or preeclampsia, or there is chronic hypertension. Let us start with the definition. So, preeclampsia or PIH, how we differentiate between them. So, pregnancy-induced hypertension, it is defined as a raised blood pressures, that is systolic blood pressure more than 140 millimeter of mercury and diastolic blood pressure equal to or more than 90 millimeter of mercury on two occasions at least 4 hours apart in a pregnant woman after 20 weeks of the pregnancy. This is known as PIH, pregnancy-induced hypertension, which is in the absence of the proteinuria. Raised blood pressures on two occasions at least 4 hours apart in a pregnant woman after 20 weeks of pregnancy in the absence of proteinuria is PIH. Or if it is associated with the proteinuria, evidence of the maternal organ dysfunction or fetal growth restriction is known as preeclampsia. So the differentiating point between the PIH and preeclampsia is the presence of the proteinuria, maternal organ dysfunction, and PII, fetal growth restriction. Proteinuria. The proteinuria, how we diagnose proteinuria. The first test for the diagnosis of proteinuria is a urine dipstick test or urine DR, and the presence of 2 or more than 2 plus of the proteins in the urine is known as proteinuria. Then if the proteins comes in the urine, then you have to quantify. There are two tests for the quantification of the proteinuria, that is 24-hour maternal urine collection or spot test, that is spot protein creatinine ratio. So 24-hour collection is obsolete these days, but it is being practiced in some part of the country these days as well. If the lab test comes out to be 300 or more than 300 in 24-hour urine collection, or if it is equal to more than 30 milligram per millimole protein creatinine ratio in a spot test, this is known as proteinuria. Evidence of maternal organ dysfunction. So for the maternal organ dysfunction, there is PET profile which include creatinine, SGPT, uric acid, platelets, and spot urine protein creatinine ratio. If creatinine is more than 1 milligram per deciliter, SGPT is more than 40 international units per liter, and platelets are less than 150,000 per microliter, it is indicated of the maternal organ dysfunction. And fetal growth restriction, it is identified by the ultrasound examination, that is Doppler test. Now let us discuss what is the pathogenesis of the preeclampsia. So pathogenesis of preeclampsia, it originates in the placenta. Defective placental function leads to the development of the preeclampsia. So what happens in the normal pregnancy and what happens in the preeclampsia? In a normal pregnancy, there is invasion of the trophoblast. The trophoblast that invades the myometrium and that invades the spiral arteries of the myometrium. There is first wave of the trophoblastic invasion, and this first wave of the trophoblastic invasion, it ends by the end of the first trimester, and this first wave, it invades the decidual portion of the spiral artery only. Then there is the second wave of the trophoblastic invasion, and it starts from the early second trimester, and it invades the myometrial portion of the spiral artery. What is the purpose of this invasion of the trophoblast? The spiral arteries, which were previously small capacitance constricted low flow vessels, they are changed into large capacitance dilated and high flow vessels, which is essential for the normal placental function. So failure to do so, that leads to the superficial portion of the spiral arteries are invaded by the trophoblast, and that is the main pathogenic factor of the preeclampsia. So failure of the trophoblast invasion leads to the superficial invasion of the spiral arteries by the trophoblast. Now as these spiral arteries, these are constructed, so it results in the increased resistance in the uteroplacental circulation and impaired intervenous blood flow, which results in the placental ischemia, because there is defective blood flow towards the placenta, which leads to the placental ischemia. Now what does this placental ischemia do? It activates the reactive oxygen species plus oxidative stress, and that release vasoactive factors into the circulation, and these vasoactive factors, it leads to the endothelial mediated end organ damage all over the body. So this pathway, it decreases the vascular endothelial growth factor and placental growth factor, which these are the angiogenetic factor and anti-inflammatory factor. But on the other hand, anti-angiogenesis and pro-inflammation endothelial dysfunction factor like SFLT1, it is increased in the pre-eclampsia. So this is the pathogenesis of the pre-eclampsia. This was about the pre-eclampsia definition and pathogenesis. In our next lecture, we will learn about the history taking, how you take history in a patient with the pre-eclampsia or which is suffering from the hypertension, and how you screen those patients, and what are the screening tests, and what are the normal lab values, and what are the abnormal lab values. Thank you so much.